Computer. I am officially recording now. All right, so like I said, this class, or these first couple classes are going to kind of review Intro to Kines. Now, when I go over this with you guys, I'm going to go through it at kind of a rapid fire pace. Again, if there's something you're like, oh, I didn't get that when we talked about Intro to Kines, stop me, we'll cover it in detail. All right, so let's kind of talk through this here. So we talked about kinesiology, right? Kinesiology is kind of looking at the biomechanics of humans, right? It's also animals, plants, everything else, but it's the study of movement of the body, right? Kinetics is the study of motion and its causes. Kinematics is the geometry of motion. All that comes into play with kinesiology. This class probably is the one that has the most miscellaneous stuff you're going to have to memorize. Kinesiology has the most stuff that is going to be didactically responsible for you to memorize, because you have to memorize range of motion measurements, positions, all that kind of stuff. Whereas with Therex, it's going to be more about actually doing some of the motions and stuff like that. So you remember anatomical position, right? Who came up with anatomical positions? Anyone remember? You guys know? Da Vinci. Da Vinci came up with the anatomical position, right? With what was I'm trying to think what the man was. Oh my God, I can't think of it off the top of my head right now. Something Vitruvian man, I can't remember what that was called. But anatomical position, right? So we have medial, lateral, anterior, posterior, distal, proximal, superior, inferior, superficial, deep, supine, prone, bilateral, contralateral, ipsilateral. All those terms should be fairly common to you, right? As well as dorsal and volar, right? Did you guys learn dorsal and volar in your kines class, right? As well as plantar and Vitruvian. Thank you. There it is, Clarice. I couldn't think of it. That is exactly what I was looking for. That's what happens when you've got a lot of stuff up here and it doesn't always work. The dorsal and volar, right? And it also comes down where we have dorsal and plantar with the foot. So all that comes into play with positions. Why I say that? Well, when you do specific manual muscle tests or you do specific strength tests, you have to have them in specific positions. You have to know if you're stabilizing the anterior segment, right? Or the distal segment, the proximal segment, the anterior portion, the posterior portion, the medial, the lateral. So all these terms will come into play as we go through this class. Upper extremities, lower extremities, trunk, neck, and skull. That's pretty. Hopefully you got those. All right. So linear motion. And I know this is one that was always fun in Intro to Kines that people always got kind of bilateral is both sides, ipsilateral same sides, contralateral is opposite sides. So maybe I will turn on my video so that you guys can see me. So if I'm saying bilateral, I'm talking both sides. If I'm talking ipsilateral, like my left arm and left leg would be ipsilateral to each other. My right arm and my left arm would be contralateral from each other. They'd be on the opposite sides. And that's going to come into play a big time when we get into dealing with spine. So that'll come in big time when we start talking about the spine. Motions, I know this is the one that gets a little challenging for you guys, right? Linear motion. When you're talking about either rectilinear or curvilinear, right? When you talk to rectilinear, it's just kind of that straight angle type motion. Curvilinear is kind of that parabolic motion, like we talked about in math, where you have that curve going on. Doesn't purely happen in the body. The body typically moves on angular motions, right? Because we have different joints. They all slide around differently, right? The wrist doesn't purely move in a linear motion. Now, we can move linearly, right? We can walk straight forward and straight back. We can jump straight up, straight down. But traditionally, the joints themselves don't move in that typical linear motion. So here's kind of looking at that linear motion versus angular motion. Yeah, the skateboard thing was great when I went through class too. All right, so why other terms do we have to come up with here? Flexion, extension, hyperextension. When we talk about ranges of motion, it's pretty rare that we're going to talk about hyperextension. A lot of people think, so this is flexion of the shoulder, right? This is extension of the shoulder. Some people think, well, isn't technically this hyperextension because I'm going past midline? Not really, because the shoulder extension is considered going past midline. Hyperextension will be when we get to measuring like your elbows, And we get those weirdos that when they extend their elbows, their arm kind of makes an L. It's definitely not me. I can barely get to extension myself, right? So hyperextension is when we go past our normative values. Sometimes the normative value for extension is just 0, right? They're just at where it ends. The elbow is a great example, right? How many degrees of extension does the elbow have? The elbow has 0 degrees of extension. It's not supposed to go past the bony block, right? When it does go past the bony block, that's when we talk about hyperextension. Plantar flexion, dorsiflexion, that occurs at the foot, right? Abduction, adduction, right? That can occur pretty much at most joints in the body. Horizontal ab and adduction, where do we normally talk about horizontal ab and adduction with? What joint? What joint has horizontal ab and adduction?
Shoulder joint.
Shoulder joint, good, right? Radial ulnar deviation, that occurs at the wrist, obviously, because that's where the radius and the ulna is. But understand, some books have actually gone away from radial ulnar deviation now. So, you know, I predict, honestly, in the near future, we're going to do away with radial ulnar deviation and just call that ab and adduction of the wrist, because it kind of makes things a little bit more uniform, right? Supination, pronation, obviously that's primarily the forearm, right? Inversion, eversion is the turn of the foot. And then protraction and retraction is primarily the scapula, right? You protract and you retract the scapula. With the scapula, what position do we normally sit in? Do we sit more in protraction or sit more in retraction?
Protraction.
Yeah, right? That's this posture. Where's my phone at? Right here, right? Protraction of the shoulders. Some of you have that pretty bad. And some of you, when we open up and you start doing some pec stretches, all of a sudden you're like, oh my God, that hurts. Because you're stuck in that protracted position. Then we have our rotations, right? We have medial rotation, which is synonymous with internal rotation, and lateral rotation, which is synonymous with external rotation, right? That's primarily going to be of the hip and the shoulder. Now, there are some books that will say that the knee has a slight bit of medial rotation and lateral rotation. We'll talk about that when we get to the knee. There's not a ton of motion there, so it's not something you have to study. Oh my God, it has 40 degrees of medial rotation. That'd be weird at the knee, right? But medial and lateral rotation is primarily the hip and the shoulder. And we have our lateral bending, right? Side bends. And circumduction. Did he talk to you guys about circumduction in Intro to Kines at all? You know, circumduction is where we kind of combine a whole bunch of movements together, right? In order for me to circumduct the shoulder, I kind of have to move through that full range of motion, that making that circle form of the shoulder. You can circumduct your foot, you can circumduct your wrist. It's kind of moving that circular motion. That's going to come more into play when we talk about gait, and an abnormal gait being the circumductive gait. Oh God, the skeletal system, right? I'm going to pick a bone with you. All right, so we have our axillar and appendicular skeleton, right? Axillar is primarily your head and thorax and kind of main body. Appendicular is out here. And so functional skeletons provide support and shape. It'd be really weird if we didn't have a skeleton. We'd kind of all look like Jabba the Hutt, or at least I would. Protects the vital organs. That's the main part of the torso, right? The main part of the torso is to protect all of those internal organs that keep you alive. Same thing with the skull, right? If we didn't have the skull, that would be bad for our brains. Well, and some of us, even having the skull is bad for our brains. Assist in motion, and also it's the main source of blood manufacture, right? Which bones primarily produce most of our hematopoietic cells? So making the blood cells. Which bones? Which group of bones? How about that? That's a little bit better of a term. Right, so in our spongy bone, right, it's mainly our long bones, right? So exactly, good, right? So it's that spongy, what's that spongy material inside the bones called? If you don't know, we'll learn tomorrow. Yes, marrow, exactly, right? That helps produce most of our blood cells. That's where a lot of our stem cells, which are those undifferentiated cells, will come from, even when we're adults, right? It produces that cell, and then that cell can kind of divide off and become whatever we need it to become. That's also where a lot of times if somebody's got cancer, they're going to ask for you to do a marrow donation, because those undifferentiated cells haven't fully formed yet, so they can use those to help provide other cells for the patients that need red blood cells, white blood cells, whatever it may be, right? But I will warn you, I've done marrow donations. It's not fun. It hurts, right? Because in order to get into the marrow to suck some of your marrow out, they've got to go through that hard bone on the outside with a needle. Doesn't feel very good, right? So marrow donation is a great thing to do, and I highly recommend all of you to sign up for the Marrow Donation Foundation. If you're like me now, I can no longer donate because I've had too many concussions now, because there's some rule about when you reach a certain amount of concussions, you can no longer donate. But back when I did donate, when it was one of my classmates had leukemia. That was back in, 88. Oh my God, that was a long time ago. Before most of you were born. All right, so axial skeleton's got about 80 bones, central and midline. The skull, the hyoid, rib cage, sternum, vertebral column are all parts of it, right? Appendicular is 126 bones, upper extremity, lower extremity, 6 regions, pectoral, shoulder girdle, arm, forearm, hand, pelvis, thigh, foot, and ankle. So as far as your boards go, do you have to know exactly how many bones is in the human body? Probably not. They're not going to ask you, the appendicular skeleton has how many bones? 126, 128, 127, 130. No. They're going to ask you what bones are part of the appendicular skeleton versus part of the axial skeleton. It's primarily the thing they're going to be concerned with. And here's that compact bone, right, that supports the body, protects the organs, stores calcium, dense and strong. We also need vitamin D to help process that calcium and get it absorbed by the body, right? What's our number one way to get vitamin D? How do we get vitamin D other than milk? Sun. Yeah, exactly, right? That's why right now there's a huge study that's come out of U of Mass saying that we might actually be in for some problems long-term from being cooped up this long. That there's going to be people coming out with massive vitamin D deficiencies from not going outside. And I could legitimately see that. I haven't spent a lot of time outside. I'm trying to get better about it, but I haven't spent a ton of time outside. So, it's harder for the body to process calcium when you don't have that vitamin D to process it, right? Oscal helps some parts, or those vitamin D supplements, but you producing it naturally is much better. It's 80% of the weight of the skeleton, forms the outer shells of the bones, right? And the cancellous or spongy bone, trabecular, I love that term. You'll never see that. It's always spongy bone. It's soft and weaker bones located at the ends of the bones. Vascular, it's a location of marrow. Provides the inner portion of the bones, also where you've got those growth plates, right? Here's kind of that normal bone composition. We're looking at the spine here. Hey, somebody just joined us. Who just joined us? I bet that was Javen. No, it wasn't. I don't know who joined us. Whoever wants to join us. Hi, how are you doing? Who joined us? I don't know. Whatever. Squirrel. So this is obviously looking at the spine. And when you're looking at this, right, that's why these spinal bodies are really nice and thick, because they've got to support the weight of the body, right? And there's tons of force, especially right now with you guys sitting down in your chairs. There's a ton of force being exerted right down on every single one of those vertebrae, which is why, when you wake up in the morning, you're actually at your tallest, because you've laid down overnight, you've allowed those discs to reinflate and kind of give you that little bit. So that's when you should get measured for height, right? By the end of the day, you're at your shortest, because then the whole weight of the day literally has weighed you down. It's interesting when they do studies on people that go out to space, a lot of times when they come back, they can be 2 to 3 inches taller than they were when they left, because they've spent all time in the zero gravity environment. Now those discs are purely swollen. A lot of times they'll come back and they'll get back pain when they first come back and land on Earth, because they're back to that G weight, the gravity weight. Here's what happens eventually to all of us. Osteoporosis, right? Or making holy bones, right? This is when we start becoming Catholic in our bones, because it becomes holy. I know you guys missed my jokes. But as we get older, we will get osteoporotic, right? Every one of us, doesn't matter who you are. Who is more likely to become osteoporotic, men or women? Yeah, women are more likely to come in faster, right? Doesn't mean that men are exempt from it, but women are more likely to come to it faster. And primarily the reason for that is your hormone changes, right? Estrogen is both a great hormone and it's also a destructive hormone. It causes all kinds of bad change in your bodies, especially when estrogen either goes out of control or shuts down. So all of that comes into play, and it can affect your bones. And then the structure of the bones, at the end we have our epiphysis, right? The ends of the long bones contains the articular cartilage and cancellous bone. The metaphysis, right, which is kind of that area. What's the other term for metaphysis? Or epiphyseal plate? The growth plate, right? And then your diaphysis is your middle or shaft portion of the bone, right? When you have a fracture, what do you think is going to be worse? Having a fracture at the end of the bone or mid bone? So what do you think is going to be worse? Okay, so I got an end. Good. Why do you think end? Because what else is at the end of all your bones? Well, your joints, right? Usually if you have a fracture mid-shaft, it's the most painful, right? If you fracture your femur mid-shaft, it hurts. Like there's no joke. That's supposedly the most painful fracture you can get is a femoral fracture, right? But at the end of the end of those bones, that's where the joint comes into play. So now you get a fracture in there, and all those pieces are now moving around in your joint, and they get pinched and crappy and sore, right? That's why people that have breakdown of the knees, one of the things they complain about is, oh, my knees are clicking, and I can feel stuff floating around in there. It's because they got little chunks of bone and what do you call it? Cartilage that are kind of floating around in there, right? Doesn't mean that fracture in the mid-shaft is not painful, but it's usually worse when you mess up the joints. So here's the fun picture of the bone. Moving on. Types of bone. We have long bone, short bone, flat bones, irregular, and sesamoid bone, right? Not to be confused with the sesame, right? Sesame is on a McDonald's bun. Sesamoid is a bone. Where's our primary location of a sesamoid bone? That's the weird bone. Yeah, the knee, right? The knee or the patella, right? The patella is that sesamoid bone. Does anyone know where else we can develop sesamoid bones? Okay, you can actually, there's the big toe. Yep, you can develop them in your feet. And most of those are going to be bone fragments more than anything. But there's also a little bone you can develop between the heads of your gastrocs, right? And they call it the fibella, which is the little beam. Sometimes you can develop a little bone between those two heads. And actually, if you look at cats, they have a natural formed little bone between their gastrocs. And it makes sense because that provides a little bit more of a tendon pull for when they jump. So it provides them with improved overall mechanical advantage for jumping. So here's kind of our bones, looking at them, right? Obviously, our short bones are kind of like the carpals and the metacarpals and all that, and the tarsals. Long bones, femur, right? Humerus. I know it's not funny, but it is. We have our flat bones, irregular bones. Let's talk about some arthrokinematics. So what is the difference between, do you guys learn the difference between osteokinematics and arthrokinematics? What's osteo versus arthro? Joint versus bone movement. Very good, exactly, right? Arthro meaning joint movements, osteo meaning bone movements. Because we're going to talk about that when we get into reviewing roll, spin, and glide, right? What's the osteokinematics and what's the arthrokinematics of the roll, spin, and glide? So purpose of our joints. Why do we have joints? Well, we need to be able to move, right? It helps supports our weight and provides us with stability, right? If we didn't have joints in our legs, we could have problems. We would not be walking as smoothly as we walk, right? We wouldn't be jumping. We wouldn't be doing all that fun stuff we do. Right, so we've got these fibrous joints, right? Synarthrosis, synostosis, and gomphosis joints. We have our cartilaginous joints, our hyaline or fibrocartilage joints. They're a little bit less, but they have some movement, right? And then we have our synovials, right? Our synovials are kind of our uniaxial, biaxial, multiaxils that contain those joint capsules, synovial fluid and articular cartilage. Synovial joints allow us the most movement. So if you're looking at these going down, that list, so fibrous, cartilaginous, synovial, goes down to the most movable joints, right? Up top, not as movable. All those come into play, though. We have all those joints throughout our whole body, so you have to know where those are. So, like synovial joints, hands, right? Cartilaginous joints, where do you have some cartilaginous joints at? Where would be an example of a good cartilaginous joint? What about your vertebrae, right? Your spine. Good. And then fibrous joints, or synostosis, synarthrosis, and kyphosis. Where do you have those? We have a synostosis right here, right? Gums are good, right? What's here? Why would there be a synostosis joint? Remember, you have that nice fiber going between those two bones, right? The ulna and the radius that kind of keep them together. You also have that synostosis joint for down between the fibula and tibia, right? So those allow very little joint, but they're very important for keeping the bones together. Also your sutures, right? Up here in your brain. They should have closed on you. If they didn't close, you got problems. I had a student once tell me, well, they told me my sutures didn't close. Yeah, no, your sutures closed on your brain. Trust me. You'd be having bigger problems if sutures didn't actually close. So here's looking at a synarthrosis. Here's looking at synostosis. And then there's our gomphosis, right? I always think gomphosis gums, the peg and socket joints. Cartilaginous or vertebral joints, our sternocostal joint, and our pubis symphysis. A lot of people forget about this joint down here. It's pubic symphysis because we don't think of it a lot. It's very important though for movement. It allows those hips to stay locked together. I have a great picture when we get to hips. Well, it's not really a great picture, but with my ex-wife, when she fractured her pelvis, she was out riding ATVs here in north of Vegas and rolled over the ATV. And when she rolled over the ATV, she had 10 fractures on her left ala, her left wing of her pelvis. But she also took her pelvis and her, pubis symphysis, and it shifted like that. So her now pubis symphysis was completely just basically ripped apart. And they had to pull it apart and snap it back together and then suture it with staples together again. Oh, yeah. It was loads of fun, let me tell you. But I've had some great pictures of that. Not of actually the pubis symphysis, of the x-rays, mind you. Synovial joints has no direction union between the joints. Uniaxial, right? Hinge and pivot, biaxial, condyloids and saddles. And your multiaxials are your ball and socket joints, right? So out of all of those, your multiaxials allow you the most movement. Again, this goes from least amount of movement to most amount of movement. And your shoulders and your hips are kind of one of the areas that have the most amount of movement in our body. They allow us in multi-directions. So when we're talking about the joints, so if we're going to talk about the shoulder joint, right, we have to talk about what bones make up the shoulder joint. We have to talk about what ligaments make up the shoulder joint. And then our capsules are what hold those joints together, right? And out of all of those, kind of the most problematic when we're seeing them in PT is that capsule portion. Because we can usually work on ligaments, we can usually work on bone. For some reason, those capsules sometimes just cause us problems, right? And you guys have heard of frozen shoulder, where somebody gets stuck and they just can't move for whatever reason. We look at the structures of the shoulder via x-ray, everything looks normal. But when they're trying to move, they just can't move. It's just completely frozen there. And it's funny with frozen shoulder, we have treatments for it, but a lot of times when we're treating the patient, it just randomly gets better. And they're like, yeah, I was in the shower last night and I reached up for the shampoo and suddenly I could reach over my head. I don't know what you did, but man, that was magical. And we're like, yep, we're the best. Mm-hmm. No idea how that happened. Not a clue. Because it just sometimes resolves on its own. It's very, very finicky when those joints that have multiple planes of motion. So synovial fluid, right? It's to help reduce friction. I like to think of synovial fluid a lot as the WD-40 of our joints, right? This uses the egg yolk theory, right? But the yolk's on you if you don't have any synovial fluid. Anyway, synovial fluid helps keep kind of those joints nice and moving, right? The cartilage job primarily is a shock absorber, right? It's going to provide a nice smooth surface and absorb shock. The tendons, right? So tendons connect muscle to bone, whereas ligaments connect what? Tendons are muscle to bone, ligaments are bone to bone. Good, right? And then we have the bursas, the cushion between the bone and the tendons. A lot of times we talk about those being the egg whites. The bursas, a lot of times I think of as kind of the couch cushions as well. So here's kind of looking at that joint capsule, right? So the inner layer is going to be our synovial membrane, and then the outer layer is going to be the fibrous tissue that supports and protects the joint. If you look at this hip joint here, right, we've got so many muscles crisscrossing over that hip joint, right? And we got some back here, connect over here, right? We got ones that go this way, we've got ones that go that way. That's all gonna make, these are my great drawings, by the way, guys. They don't get any better than this, right? Those all make up that joint capsule, because that's what keeps that head of the femur into the acetabulum. So if we don't have that good patent or functional joint capsule, that can cause major problems, right? You'll talk about it, especially in the shoulder, where you get a patient that the joint capsule has become lax, right, or is not as tight as it used to be, and they'll end up with subluxations, where the shoulder will just drop out of joint. And it's not that it fully kind of dislocates, it just kind of slips down, and now the head of the humerus isn't where it's supposed to be. Well, we're going to have to strengthen those muscles to keep that head of the humerus in that shoulder, because we want to keep them from actually truly dislocating. So here's kind of looking at that synovial joint, right? We got that joint cavity containing the fluid. We got our bones, keeps everything nice and smooth. Labrums. Okay, so just so that you guys know, these are called labrums. They are not labias. Labrums and labias are totally different things. And I'll tell you a funny story about that. I had a patient, old guy, went to see him, and I'd see him at home health, and he kept talking about how the doctor said he tore his labia in his shoulder. And every time he says it, I can hear his wife out in the kitchen just laughing her head off. And she's like, come here, come here, come here, come here. I'm like, what? And she goes, don't correct him. Don't ever correct him. It's going to be a labia in his shoulder forever, because it just makes me laugh every time he says that. Right? So labia is something totally different than the labrum, right? The labrum is the ring that kind of helps keep that socket sucked in there, right? You have a labrum around your shoulder joint, you have a labrum around your hip joint, right? Labia, that was explained in your reproductive anatomy class. I'm not going to explain that anymore. And if you don't know what that is, I can't help you anymore. But you want to make sure that you don't say, and the patients will say that. And so if you can correct your patients, please do. I tore my labia in that rotor cuff. No. First of all, you're saying everything wrong, right? You tore the labrum or pinched your labrum, and it's your rotator cuff. Just makes the patient sound a little bit smarter, but you may get those people that might get mad at you and tell you, I've got a labia in my shoulder. I'm glad for that. Congratulations. I don't know how you accomplished that. But it helps deepen that fossa, right? It's there, and it's also down at the acetabulum. Bursas, right? These are those padded like sacks. Again, I think of these a lot of times like a couch cushion. There's a couple of these down in the knee. There's a couple of them in the fingers, and then also in the shoulder joints, elbow joints. They just kind of provide a little bit of a padding under where those tendons attach to the bone. Next. Oh God, the planes, right? This isn't talk about southwest versus frontier. This is talking about, joint, your motions, right? We have our sagittal plane that divides our body this way, right? Now, sagittal planes passes through the body anywhere going from front to back, right? Mid-sagittal crosses right in the dead center of us. Frontal plane or the coronal plane divides us between anterior portion, posterior portion. And then transverse kind of cuts through us. Well, why do we need to know that? Well, because motion occurs in certain planes. So if I'm doing elbow flexion, what plane does my elbow flexion occur in?
Sagittal.
Sagittal, good, right? Why is that going to become important? Well, because in order to do manual muscle testing, we have to know that gravity is going to affect elbow flexion in the sagittal plane. Whereas if we can move that over and move it more in the frontal plane, we can eliminate gravity, so sideline. So that's kind of the way we think about these things when we're talking about manual muscle testing. It'll come more into play when we start talking about manual muscle testing, but this is all going to come into play when we talk about the motions of those joints. So we do have to know that, right? Ab and adduction occur in the frontal plane, right? What motions occur in the transverse? I'll talk about mid-sagittal in a second, Tyler. What motion occur in transverse plane?
Horizontal shoulder abduction.
And more rotation too, right? Our rotations primarily occur in the transverse plane, right?
Medial rotation, yeah.
Yep. So the mid-sagittal, so our sagittal is just the line. So if I take I got a pack of Sharpies or stickies here, right? If I take it and put it straight out from anterior posterior like this, that is a sagittal plane, right? When it comes directly through the mid part of my body, that is mid-sagittal. So if it crosses right kind of through my forehead, down through my sternum, down through my nose, that's our mid-sagittal line. Whereas
Gotcha.
any other way that it passed through, so even at our shoulder, we have a sagittal plane, right? But it's not mid-sagittal. You never get on the wrong plane. You might go someplace you don't want to. So we talked about sagittal. I don't have to go through these. I already talked about those. Fantastic. The way these look at it is where they all meet is kind of that center of gravity, right? Where is your center of gravity about located in the human body? Does any of you know? I need my coffee for the morning. So your center of gravity occurs in your pelvis, right? It's about at the S2 level. So somewhere around S2 is where that center, the true center of your body gravity is. Now it's going to depend upon your build, right? Center of gravity is going to be where that kind of gravitational line pulls that keeps you even across your body, depending upon how you're built, right? If you've got chicken legs and got big old arms and skip leg day, center of gravity might be a little bit higher, right? If you got a little bit of a donk and kind of cankles, center of gravity might be a little bit lower. So all of that comes into play, and that's kind of our pivotal point is where that center of gravity is. That allows us to have the kind of the motion that we do moving around. They're just kind of looking at the sagittal axis, the frontal axis, the vertical axis, which allows us the rotations. So the number of planes in which a joint can move is called degree of freedom, right? The more degrees of freedom the joint has, the more motion occurs at it, right? Uniaxial joint has 1 degree of freedom. So if it's only got one kind of motion, it's uniaxial. Biaxial, 2 degrees of freedom. Triaxial or multiaxial has 3 or more degrees of freedom, right? All that comes into play in the positions which the joints can move. The more degrees of freedom the joint has, the more functional that joint truly is, right? We do a lot of stuff with our shoulders that are multiaxial joints. The downside is the more degrees of freedom that joint has, the more likely it is to get injured, right? Think of your ankle, for example, right? Your ankle's got a ton of movement, doesn't it? But it's also one of our most injured areas because, well, we walk. So the more degrees of freedom something has, the more functional it is for us, but also the more likely we are to injure it, right? It's pretty rare, that you actually injure your elbow joint itself. You may injure the muscles around the elbow, but injuring the joint itself is pretty rare. But your ankles and your wrists, you tear them up quite a bit. Let me move this group chat up so I don't keep you guys too late today. So let's talk about this. Let's talk about the indicating the degrees of freedom for each of these. Let's move here. So how about the shoulder? How many degrees of freedom does the shoulder have? What do you think? Let's get my little annotate here. How many degrees of freedom? How many motions does the shoulder have? Okay, 3 or more. Right? It's multiaxial. Good. What about the elbow? A lot. I like that. What motion occurs? Right, 1 degree of freedom. Good. What about the wrist? Yeah, okay, 2. Now, some people will say it has 3, and this is not a pure kinesiology, but if you're a hand therapist or something like that, they may argue that the wrist has 3 degrees of freedom because they'll call circumduction another degree of freedom, right? So when the wrist can kind of roll around like that. But in reality, that circumduction is just a combination of all the movements the wrist does, so it's not a truly free movement. How about the hip? Good. The knee? Okay, so yeah, traditional 1, but again, when we start talking about the arthrokinematics and the osteokinematics of the knee, sometimes we can argue having 2 degrees of freedom because there is some rotation with it. And then the ankle, what are we going to call the ankle? 2. Good, right? Bingo. Good job, guys. See, you learned something. So let's talk about some arthrokinematics and joint motions, right? So we have arthro versus osteo. We already talked about. Osteo is the bone movement at the joint. Arthrokinematics is the joint surface motion, right? So that's where the two bones interact with each other. We need to know these when we're moving it through. So gross movement of the shafts of bones rather than the movement of the joint surfaces are what separate that osteokinematics from the arthrokinematics, right? When we are measuring goniometry, we are measuring the osteokinematics of the joint, right? Goniometry is the measurement of the angles in that joint, particularly those angles at certain positions, right? So when I bend my elbow up, we're going to measure the osteokinematics of the elbow, the bones moving on each other, right? And come up with how many degrees does my elbow bend. And you'll have to know that there are specific degrees for each of them. So let's talk about range of motions here. What is PROM? Passive range of motion. Good, right? So if I say you're going to do passive range of motion on a patient, who is actually doing the movement? Yeah, PTA, PT, or a machine, right? We could have, there are passive range of motion machines, right, that allow that to happen. So that means the patient's doing nothing. So the step up from that at the bottom, we have, I know we have it kind of out of order here, but the second step is this AAROM, right? Aaron, are you here? AAROM means what? Active assisted, right? Good. So when we move from passive range of motion to active assisted, at that point, the patient is starting to move some of it. Present. The patient is starting to move some of it, but we're still providing with some support, either by maybe a TheraBand or a machine or however we're doing, even the E-stim or something like that, could technically be an AROM function. And then we get to AROM, which is active range of motion, right? That is where the patient is doing 100% of the work. When I bend my elbows, I've got nothing helping me here. I'm doing it all on my own. I'm not RoboCop. And then we got from. What's from? Nope. Good guess, though. Nope. Functional range of motion. So this is functional. Let's see if I can draw. Functional. There we go. Functional range of motion. So, for example, let's say my shoulder, right? So if I lift my shoulder up, how many degrees range of motion does my shoulder have? Or should it have? What do you think? I'll give you a hint. It's a straight line.
180.
How many degrees should the shoulder have? What do you think? Straight line is how many degrees? 180. Can you guys still hear me? Yeah, good. Okay.
180?
180. Good. All right. I was getting concerned there because I saw some people moving around in the chat. The participants, I thought I might have been getting disconnected because Cox is fun like that. Right. I should have 180 degrees. Do I need 180 degrees of motion? Oh, I didn't hear it. It must have clicked out on me. Sorry. Do I need 180 degrees of motion to function? No. Right? I can get around without having to reach here. How much stuff do you do in this position here? Not too much, other than raising, can I go to the bathroom? Can I go to the bathroom? Right? But we need about 135 to function. Right? We need to be able to reach about here, especially in order to get up here and, either shave our heads or wash our hair or do anything, right? So there's functional range of motions that patients have. And so that kind of gives us an idea when we're working with patients. If we can't get them back to full range of motion, we want to try to get them to at least a functional range of motion. Aboriginal Aquatic Resources and Ocean Management. Yeah, I don't know why that's on there. I think I had a joke with that, and I can't remember what it was. Range of motion we talked about is an arc of motion in degrees between the beginning and the end point of a specific plane. It may include one or a series of joints, and the ranges are going to go between 0 and 180. 180 is the most range of motion you have in a joint. I've heard some person go like this, though. But see my shoulder, I have more than 180 degrees range of motion because I can go the whole way around. No. You're actually stopping here with your range of motion, going out into abduction, rotating it back around in internal rotation, and bringing it back around. So as far as flexion extension goes, you still only have 180 degrees, right? But we do talk about the circumductive movement when we actually are exercising a patient, but we don't measure that. So shoulder is going to have 180 degrees of motion. Are there any other joints that are going to have a full 180 degrees of motion? What do you think? Is there any other joint in the body you can think of that has a full 180 degrees? That'd be weird if we did. Right? Could you imagine if your hip had 180 degrees of motion? That'd be pretty impressive. I mean, some of you may have a good bit of flexibility in those hips. Most of us don't. But shoulder is one of the major ones that has that full 180 degrees. The elbow's not at 180. That'd be really weird if our elbows went to 180, because then it'd be back here, and I'd say you've got a broken elbow. So passive range of motion we talked about. An examiner or therapist performs motion or a machine. There's no contraction in the muscle, right? Now, typically a patient is going to have greater passive range of motion than active range of motion, especially if they're injured, right? If you move that elbow and they've got an elbow strain or something like that, you'll be able to move that passively a greater distance than when they move it, because when they start contracting those muscles, they start getting pain. And when they get pain, they guard and they don't go their full range of motion. Our goal is to get past that pain so their passive and active can be as close as possible. Activists, we covered all that, right? End feels. Did Dr. Johnson cover end feels with you guys? Yes? That was a quick. Okay, good. So whenever we do range of motion, right, which is goniometry, one of the first things you are going to do with the patient is going to move them through their full range of motion, because your goal is to get the end feel. If you don't have that, you haven't done your full goniometry. So you have to move them passively through it to get what that end feels like. And it does require hands-on experience. There's no way I can ever explain to you what a spongy end feel is unless you actually feel it. So normal end feels, bony or hard, right? Where is the only place in the body you should encounter a bony end feel? Elbow, right? That's the only place. Now, some people say at the neck you get a bony end feel, not really. Like the wrist, they get a bony end feel, not really, right? Bony should be at the elbow only. If you get a bony end feel elsewhere, it's an abnormal feeling, right? So bony is when, what bony point is this here? What's that tip of your elbow called? Your olecranon, right? When your olecranon goes into the goal, and it goes ole, 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 and goes into the olecranon fossa, right? That's where that locks in. That's that bony end feel. Soft tissue approximation. A lot of us have way too much of this, right? Soft is where you get either muscle on muscle, muscle on fat, fat on fat, something to that effect. That's where the body itself kind of squishes together, right? Good example of that for some of us is going elbow flexion, right? Where you've got your forearm muscles and your humeral muscles kind of banging against each other. That's where you kind of get that soft tissue. Now, some of you may not have as much tissue there and can get kind of a firm end feel, where it's actually a muscle stretch or capsular stretch. Most of us will get a soft one, right? If you take your hip and bring it up, a lot of times we'll either get either firm or soft, depending upon how stretchy and loose you are, right? And then soft tissue stretch or firm end feel is where we get that muscle kind of guarding, right? So going up with your wrist is a good example of that muscular, that stretch end feel, that soft tissue stretch or firm end feel, because all of your wrist flexor muscles are resisting that motion. So there's all those. And then we have abnormal hard again, is where our hard shouldn't occur. We have abnormal firm, where it occurs sooner or later than it's normally, right? So if I get a firm end feel here in the elbow, and I'm at 90 degrees, that would be an abnormal end feel for the elbow, right? Abnormally soft would be where you have too much soft tissue, and that's where we get into that boggy end feel. I love the term boggy. Boggy is such a great one. Boggy is where you got a lot of fluid and it's not letting you kind of move through that joint. And empty is the one we're going to probably encounter the most, right? How are you going to know when you have an empty end feel? What's the patient probably doing? Screaming, yeah, right? So that's where we're working on the shoulder, and you get here and they're like, ow, 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 I can't move any further. That would be an empty end feel, right? Or they start resisting you and pulling back. You can't get to a normal end feel at that point, so that's empty. And so there's the descriptions of all those. We'll go through this. We're getting a good chunk through this, which is good. So arthrokinematics is the definition of the movement of the joint surfaces. In clinical settings, we call this accessory motion, right? This is where we talk about joint play, joint mobilization, and joint manipulation. So when we're doing range of motion, we are doing osteokinematics. When we are doing joint mobilization, we are doing arthrokinematics. We are moving the joint itself, not necessarily the bones. Manipulation is often a term that you hear more in the terms of a chiropractor. They kind of coined that term. We usually use mobilization for these, right? So roll is a common term you'll hear with this, with the osteokinematics or arthrokinematics, where we have a rotary motion, right? This is where that femur, right, moves on the surface of the tibia. That's a roll. We have a glide that occurs too, right? Or slide or glide. Slide and glide are the same terms. So some books use slide, some books use glide. Please understand that in your boards, depending upon who wrote the test or wrote the test question, they may use slide or glide. They're the same thing, right? So slide is where the one surface slides on another. And then you have spin, which is an accessory rotary motion, right, on a fixed axis. Usually 2 or more of these motions occur simultaneously. So you'll often have spin and glide, roll and spin. All of this comes into play when we're talking about those bone motions, right? So this is where that convex concave rule comes in, right? So convex is forming what? Convex forms a hump. Concave, you dive into the cave, right? So all of that kind of comes into play when we're talking about these motions. Because depending upon which surface is moving, whether it's the convex on the concave or the concave on the convex, will depend upon those spins and glides. So here's kind of what roll motion looks like. That's a ball rolling down the hill, right? There's glide and there's spin, right? I don't even know if they make tops anymore or dreidels, but that's a top. So the convex concave roll. This is by far one of the most important things you have to get out of kinesiology. You have to know this literally like all the joints in your body, because they love writing board questions on the convex concave rule, because it is a simple thing to write board questions on that is a complex topic, right? So when you have a convex surface, it's curving outward, or I think forms the hill. It will move in the opposite direction of the bony segment or shaft of the bone, and will roll in the same direction, but glide in the opposite. So when it slides, it goes in the opposite. When it rolls, it moves in the same. Concave is curving inward or forming a cave, right? Forming the back cave. Moves in the same direction of the body segment or shaft of the bone. Will roll and slide in the same direction. So a lot of time when we're talking about concave movement, everything's going to move in the same direction. That's the nice thing to think about, right? So here we have a concave surface, right? So we're looking at the bone moving up. If this is moving up, the roll is going to be forward and the slide is going to be forward. When we have a convex, the roll is going to be one way and the glide or slide is going to be the other. So here we look at the femur, right? So when we look at the femur moving, right? So here's my femur, right? Here's the surface of my tibia. I have a convex surface moving on a concave surface when I'm moving the femur. So when I'm moving the femur, what am I doing? I'm standing up. I'm doing a sit to stand, right? So when I move that femur and I start standing up, it's going to roll. I'm going to get my little drawing here, right? It's going to roll anteriorly and glide posteriorly. Did you guys understand that in Intro to Kines? Or was that a complex topic that kind of got you fried a little bit?
Definitely complex.
Right. And we're going to hit this several times because even when we get to the knee, we're going to recover all of this all over again. So don't freak out if you don't 100% get it. By the end of the semester, you will have this, right? So again, we have our convex surface moving on the concave surface because the tibia is just on, think of the tibia as locked into the ground, right? It's not moving anywhere. And when you're standing up, right, the femur is what's moving. So when the femur moves on the tibia, it rolls anteriorly and glides or slides posteriorly to lock in. Because if it didn't slide, right, if it just rolled, it would roll right off the tibia. So it needs to glide a little bit so it sucks into that little suction cup of the tibia. Does that make sense overall? For a little bit, at least for now?
Sure.
Sure, I like that, sure. So then when we have something like the tibia, so now we're going to reverse. Do I have a picture of the tibia moving? I don't think I do. No, okay. So let's go back here. So now when we have the tibia moving, so now we're doing a kick out, right? Or a long arc quad or a short arc quad or something to that effect where you're moving the tibia on the femur. So I'm going to go over here to this other side over here. So now we're taking this tibia and going this way, right? The roll and glide are going to be in the same motion because it's the concave surface. All right, joint surface and shapes. Ovoid joints are concave surface on one bone, articulated with a convex on another bone. Wrist, the MCP, the MTPs, all of those are ovoid joints. The saddle joints are the sellar joints, which also, if you remember back with the brain, you had a part of the brain called the sella turcica, right? You guys remember that? And the sella turcica was the horse's saddle in your brain. That's where all those, what sits in the horse's saddle in the brain? What structure of the brain? You guys remember that at all from anatomy? I know it was just last semester, but your pituitary, right? Your master gland kind of sits in that horse's saddle. And that's also where a lot of your sensory olfactory nerves come kind of off and then go through all those little cribriform plates, right? So your saddle joints are the convex concave surface, each articulating surface, right? The SC joint, the CMC joint of the thumb are excellent. What's the SC joint? The what? So I often say this, I'll talk about the SC joint and the AC joint, and some of you guys will get a little confused by it. So the SC joint is the sternoclavicular joint, and the AC joint is the acromioclavicular joint, right? So that's dealing with the clavicle, right, or that collarbone. So the SC joint's a common saddle joint, right? So this is looking at these. Here we have the convex and concave surface again. So when a joint is congruent, the joint surfaces have maximal contact with each other, are tightly compressed, are difficult to distract or pull apart, and are called the closed pack position. When the joint is most in contact with each other, that is called the closed pack position. In the closed pack position, we can do no mobilization. Because if we try to mobilize something when it's locked together, it ain't gonna go nowhere. So closed pack doesn't help us. Closed pack is the position of stabilization, right? When your knee's in full extension and those bones are locked into that kind of maximal contact with each other, that is kind of your most stable position of your joint. We're not going to mobilize a knee in full extension because you can't, right? That's considered the closed pack position of the knee. When the surfaces are incongruent, especially when they're maximally incongruent, that's where we call the open or loose pack position, right? That's usually a resting position, or it's also a position of mobilization. So stabilization, closed packed. Mobilization, open packed. You need to know that when we get into joint mobs, because like if my elbow is in extension, do you think it's in closed packed or open packed? So, but yeah, it's close packed, right? Try to mobilize that joint. Try to pull that joint apart while it's in extension. You can't do it. I can't mobilize it anywhere. It doesn't go anywhere. It's locked. In order to mobilize my elbow, I have to move it into a more open pack position, and then I can actually distract those joints and do joint mobilizations. So that's why closed versus open packed is important. If you don't know those, it can be problematic because you have to be able to look at that. I'm going to finish with the accessory motion forces, then we'll call it a day. So accessory motion forces. You already talked about some of this with Dr. O'Neill in modalities, right? Traction or distraction. Both of those are the same. So when you see traction, think also distraction. That's where you pull the bones apart, pull the surfaces apart. It is easier to pull the surface apart when it's in open pack position. It's easier to pull things apart when they're not tight together. It is easier to approximate or push those surfaces together with compression if they're in closed pack. It's easier to move them together and get them nice and tight when they're in closed pack. We will use both traction and compression in order to help relieve pain, right? Sometimes if somebody's got neck pain, putting a little pressure and compression on the neck actually makes that neck pain feel better. Sometimes this makes it feel worse and we have to distract the neck, right? Shear. Shear is when the bone end moves parallel and opposite to the direction. So when the bones are moving in a line and opposite the other thing. Now, shear will be a force as well. If we don't have that articular cartilage, if you are doing a shear motion, you're actually going to start tearing those bones apart. So that's why articular cartilage is really important, right? And then bending is compression on the same convex sides and distraction on the opposite side. So if I bend a bone, eventually it's going to break, right? Our muscles bend perfectly fine though because they have elasticity. And then rotary is twisting or torsional force. So there's traction, pulling things apart. There's compression. There's shear force when the bones are moving opposite each other. A lot of times shear force is what we're going to do when we do joint mobilizations. You know, if this is my knee here, and it's my little patella, right, my little sesamoid bone. A lot of times what I'm going to do is want to move these bones on each other, either up and down, or I can even move them in the opposite direction. And that's going to create a shear force. But if I don't have that nice articular cartilage in here and those menisci, that can actually shear off parts of these bones and you end up with bone spurs because of it. So we have to make sure that everything's patent or functional in their joints before we do shearing. And then bending force is kind of what it looks like. The traction is where it's getting kind of spread apart. The compression is the opposite side. This is just like that cantilever idea that we talked about in physics, where we talked about a cantilever being that bending piece of metal where the outside is actually stretching, the inside is actually compressing. And there's rotary when we're moving stuff around. A lot of times rotary motion is going to be supported by really strong ligaments in order to keep those bones attached. So those have a little bit of motion, but not a lot. Your knee is an excellent example of it. Your knee's got 4 primary ligaments, right? ACL, PCL, LCL, and MCL. Their job is to limit how much translocational force that knee has. How much does it rotate? How much does it move forward and back? It's very important because if our knee moves all over the place, we're not going to have a good stable surface to walk. All right, that's where we're going to call it for the day. We'll start with the muscular system on Monday. So tomorrow morning, I'm going to stop the recording right